Good afternoon to all of you. Since we are a little bit ahead of time, we can go faster. The dinner will be ahead of time. So. Okay, now there is some order. I'm not sure that it was planned directly, but several parts of this symposium, but now we are getting to, I may call it the more family part of the business, which is part family, part science, part, but this is nice. By the way, I hope that those from the family, they can add inside some anecdotes about the family that it will be more saucy, so, but it's up to you. So. Okay, the next presentation is by Professor Shoshana Revel Vilk. In 2002, she joined the Department of Pediatric Hematology and Oncology at Hadassah Hospital as a senior physician, and in 2012, she was appointed the head of the Pediatric Hematology Center in the same place. Currently, she is at the Gaucher Clinic at Pediatric Hematology Oncology Unit in Shaarei Tzedek Medical Center and is involved in several studies of the new direct oral anticoagulants in children. Please. By the way, several months ago I talked with Michel on the family, and you unwillingness, you became very famous in Israel. So.
Good afternoon. First and after all, I'm the daughter of Michel, and I'm really honored and very, very excited. You can hear from my voice to be here and talk with all family and friends. And I'm a pediatric hematologist, oncologist. I trained in blood and cancer in children, but as was mentioned, in about more than a year ago, we had a crisis where I worked at Hadassah, and I had to leave. And for 1 month, I was unemployed. I worked in outside of the hospital, and then I was recruited by an amazing doctor, Professor Ari Zimram, which is the head of the Gaucher Clinic at Shaarei Tzedek. And this is one of the reasons I thought I will talk about Gaucher disease. And I think during my talk, I will also show you other reasons which are connected to my father choosing the topic of Gaucher disease as a model for rare diseases. And I want to start, I'm a pediatrician, so I want to start with a story. And this is actually one of the first patients I had in the Gaucher Clinic at Shaarei Tzedek. And he's a 20-month-old baby, infant, actually, almost 2 years old. And you can appreciate that although he's 2 years almost, he's quite small for his age. And he actually came to us almost not able to walk, not able to sit, all the things children in his age for sure do. And he had this very large abdomen, as you can see here, being very weak, just lying on the bed. And this is how he came to us. And his story goes that he was born normally. And I don't know how many of you are physicians, but here is a growth chart. So you can see here we put on the chart the weight and the height of the children to see how they are growing during their age. And you can see here the month, and here you can see the weight, the kilos, and the centimeters. And you can see here that he was born normally. He was born an average age, average weight, and somewhere during the course of the first year of life, at 11 months, he started breaking his growth chart, almost not growing in height and weight since the age of 11 months. And he had other symptoms when he came to his pediatrician. He was unwell. He had these abnormal eye movements that you can see He was developmental delay, so he didn't sit, he didn't walk, he didn't turn from abdomen to back and not verse wise. He had this swollen abdomen, which you show on the picture. He had this recurrent cough. And when we took blood tests from him, we could see that he had a low hemoglobin and a low platelet count. So he had those several manifestations at that age. And it reminds me of this story of this blind people with the elephants. So I'm sure all of you are aware of the story, right, of this elephant that there are 5 blind people are touching the elephant, and one is touching the tail, and one is touching the skin, and one is touching the neck, and each one of them is thinking about something else. So I wrote here that the neurologist thought about his disease, the hematologist, that a blood specialist, thought about another thing, the pulmonology, because of the cough, thought about another thing, the gastroenterology, so a doctor is specialized in eating, and the gastrointestinal tract thought about another thing, the hormone doctor thought about another thing, and really nobody could figure out what this child had. And I think this is the motto of what, when we talk about rare diseases, this is the real motto. So if you don't think, you won't look, and if you don't look, you won't find, and if you don't find, you can't treat. And I want to show you during this course of this presentation how these things should come together in order to help those patients. So I want to talk about a little bit about rare diseases, and I will explain you about what they are. I will talk about Gaucher disease because that's what I'm doing now, and what we learned from Gaucher disease as a rare disease, and what questions are still open in the field of rare diseases. So this is the numbers when we talk about rare diseases. So it is thought that about 1 in 12 persons will have a rare disease. And there are some definitions that are used by different countries. You can see here the different definitions. It depends on regulatory questions, but it doesn't really matter. So the USA say, in the USA it's called that if you have a disease less than 200,000 patients, it will be a rare disease. In the European Union is 5 in 10,000 people. So it's not patients, 5 in 10,000 and 1 in 2,500. And in Japan, it will be a disease that is found in less than 50,000 patients. So it seems to be a very rare thing. But when you look at the numbers, almost more than 300 million people in the world have rare disease. Because we don't have just one rare disease. We have many rare diseases. So all together, there is many patients with rare diseases, but each one of them would have a different type of disease, different cause of the disease, different treatment of the disease. Altogether, it's 8,000. It's even more. So 300 billion is more than what we have in cancer or other diseases, but still rare diseases, you will see, have disadvantages or less research because they are rare. About 80% of the rare diseases are genetic, and about 50% of the rare diseases are affected by children. This is the numbers in Israel. So the definition in Israel for rare disease is 1 in 10,000 people, quite similar to the European one. And it's estimated that about more than 60,000 patients in Israel have a rare disease. Not all of them have the same rare disease, but have some type of rare disease. And what is the problem with rare disease? I think some of the things you can think about them yourself. So there is a problem with misdiagnosis, and the numbers go that each patient with a rare disease usually has to go to about 5 physicians before he gets diagnosed with rare disease, and he gets 4 different types of diagnoses until he gets to the right diagnosis. There is lack of knowledge. So once you get diagnosed, it would be probably that your physician, your pediatrician, or your family physician won't know anything about your disease. So nowadays it's much easier because we have Google, we have Dr. Google, everybody can Google their diseases, but think about times when it was not available, and also we know that Google information is not always the correct one. So the lack of knowledge is a real issue. And also, because it's a rare disease, it's very hard to study it. It's very hard to study the patient. It's very hard to do good studies, as was shown during the first part of this symposium. So there is lack of treatment, The cost of treatment is very high because it takes a long time and it's very hard to produce treatments. And research support in rare diseases is late. So let's talk about Gaucher disease and we'll go back to rare diseases. So this is the first thing is connected to my parents. So this is Gaucher. He worked in Paris. And this is his thesis, which some of you in the audience can probably read it better than me. It's his thesis about a lady, a 32-year-old lady that had a huge spleen, and he saw these cells in her spleen biopsy which were abnormal. Eventually, it was turned to be Gaucher, and in honor of his name, it was called Gaucher. I talked with my parents about it, and they said that maybe he was a lefty because Gaucher is gauche, so maybe that's the reason why it was called Gaucher. But the disease is called on his name from his first description in his thesis in 1992. But it took more than 50 years to get to the reason of the pathogenesis of Gaucher disease. And this is a second connection to my father because the physicians that described the glucocerebrosidase, which is the enzyme that is defected in Gaucher disease. So one of them is Roscoe Brady, but this is David Shapiro, which you can see here in asterisk. At the time that the publication in 1965, he was already working in the Weizmann Institute. He's one of the first physician working in the Department of Organic Chemistry in the Weizmann Institute. So what do we have in Gaucher disease? We have this compound, which is a protein glucose, which is called glucoceramide, and it has to break down to glucose and ceramide. And the problem in Gaucher disease is that you have a problem in this enzyme, so this protein doesn't work, and because of that, you have the accumulation of this compound, the glucoceramide. So this is actually all the story of Gaucher disease. But the issue here is that we have many cells, many places in our bodies this compound can accumulate. So here you can see, again, that it accumulates in these macrophages. It's part of the immune system. And this is the phenotypes that we can see in patients with Gaucher disease. So we see this huge abdomen as we saw in our patient with a large spleen, a large liver. They have anemia because the bone marrow is also compacted with Gaucher cells, and also the spleen takes all the blood cells. They have bone disease with bone pain, bone crisis. They have thrombocytopenia, low platelet count with bruises, which comes back to what I've done. Also, in pediatric hematology, I'm working a lot of bleeding problems. And they have growth retardation because of all of these issues. And what you see here is the type 1, which is the most common type of Gaucher disease, but there is also type 2 and 3 Gaucher disease that involve also the brain. So on top of the manifestation you see here, they also have brain problems. It took another 20 years from the description of the glucocerebrosidase to find the mutation, and in 1985 the gene was isolated and the major mutations were found. Just a word about the genetic phenotype of the Gaucher disease. So it's an autosomal recessive disease, meaning that the parents are carriers. So here you see a father carrier, a mother carrier, and statistically they can have 4 children, which one of them will be healthy, 2 will be a carrier, and 1 will be affected. It's a statistic, so they can have all their patients affected or all the patients unaffected, but that's basically what we call an autosomal recessive disease, and this is a Gaucher disease. So why do we talk about Gaucher disease in Israel? Because the Jewish connection, and actually it's the name of the film, it's a French film, that's a French name. The American name is Holy Rollers, so that's I think, third connection to my parents. So the French name is called Jewish Connection. And actually, Gaucher disease is the most common genetic disease affecting Ashkenazi Jews. And you can see here the carriers. So 1 in 70 Ashkenazi Jews will be a carrier of Gaucher disease. And the disease, if 2 Ashkenazi Jews marry, then 150 will be affected. And you can see here the carrier in non-Jews, 1 in 100, and the affected would be 1 in 50,000 non-Jews. And there is a big discussion if there is a founder effect. We won't talk about it, but if somebody's interested, we can talk about it later. And there is a very important phenotype-genotype association. So here you can see the different mutations. There are more than 800 mutations, but I just aligned the most important ones, the ones that are relevant. And you can see here that basically a child could have either a mild mutation. This is the Ashkenazi mutation, the N370S. And so if he got a mild mutation from his father and a mild mutation from his mother, it would actually be type 1. Doesn't matter what he got from the other side. So if he got mild mutation from his father and a severe from his father, it will still be type 1. And type 1 could be actually an asymptomatic person. This is a pilot that was found to be Gaucher disease patient because his mother did a carrier screen. So she was found to be a carrier of Gaucher. And then they tested him, and he was found to be homozygous for the Gaucher disease. So he's actually a patient because he's homozygote for the mutation, for the Gaucher mutation, but he's healthy. And this is a child that also is quite healthy that was diagnosed with Gaucher disease. And this, you can see here on this side, the more severe forms of Gaucher disease. This is a type 3 that has, again, got from his both his parents a severe mutation. And this is our type 2, which are very, very sick and die in a very young age. So there is a very broad spectrum of phenotypes in Gaucher disease, and it's somewhat related to the genotype. And in 1990s, so 5 years after description of the gene, the first therapy of Gaucher disease was given, and I brought this again for a connection to my father because it really shows here the nice connection between the scientist, Brady, that found the glucocerebrosidase, the pharma, in this case is Genzyme. There are now other companies that do therapies for Gaucher disease, but you can see here that he got a prize from President Bush, being one of the first pharma that really took the risk of treating a rare disease with very few patients and bringing it forward. And this is the Ashkenazi family, which is Brian Feldman, that pushed the scientist to give the drug, and this was actually the first patient that got the drug for Gaucher disease. And if somebody is interested, you can go and Google him on YouTube, and you can see a film. He's describing how he was very sick when he was young and how he got the disease, and he's actually now the head of the Association for Gaucher disease in the US, Brian Feldman. As I said, after the first therapy, which was here, other therapies which are recombinant. So recombinant means that they were made not by purification from the placenta, like the first enzyme. They were made in the company, a recombinant enzyme. So since the first one, we have now 3 what we call enzyme replacement therapy, and 2 that are substrate radiation therapy. And I just showed you here the picture. So you have to be normal. You have to have enough. You have to have a substrate, but you have enough degradation. So you have to have not too much of the substrate and enough degradation. If you have too much substrate, if you have accumulation, you have Gaucher disease. If you want to treat it, you can give the enzyme, and then you can go back to the balance. Or another way of treating it is giving a medication to reduce the substrate, and then again to get to the balance. As long as you're balanced, you don't have manifestation of your disease. And there is many issues about the drugs, and as I think were alluded before, talking about multiple sclerosis, not all the drugs are the same, but basically nowadays when a patient comes in and he needs treatment, we say all the drugs are the same, although we do as physicians find some difference between the types of therapies. So what's important for patients besides therapies? Associations. So there is many associations. This is the National Gaucher Foundation. As you saw, Brian Feldman, he's the head of this association. There is an Israel association, which there's a journal, which is called Gushiton, which gives much information about Gaucher disease. There is an awareness desk. So the 1st of October is the International Gaucher Day. I'm sure you were all aware of it. So this is ways to really promote and help patients with rare diseases. Another way to promote and help patients with Gaucher disease and help us as researchers to really learn about the disease is patient registries, and there is many registries in Gaucher disease, both large single ones, national ones, and international registries of Gaucher disease. So if everything is so great, where are the problems? And that's what I want to talk now about, the problems of really treating patients with rare disease. So one of them is the cost of therapy. And this is a manuscript that was written about 10, 15 years ago with the same author, one of the pioneers in the field of Gaucher disease, talking about the economic malpractice in the treatment of Gaucher disease. Because the pharma wants us to spend a lot of money treating the patients. The governments want us not to to spend so much money to the patient, and the patient in the middle don't know really what they should be done. And when we talked about who to treat and what to treat, that's exactly how what he describes in this manuscript. So the malpractice in treating Gaucher disease is a very important topic, and I will address it shortly. Another topic is the diagnosis and misdiagnosis. And actually, this is interesting because this is hemato-oncology, so a specialist like me that were presented with a case, a typical case of Gaucher disease. And you can see here that only 20% of them thought about Gaucher disease. So you think that the experts they thought about other diseases, but only 20% of the experts that were presented a very typical case that if you would Google splenomegaly, anemia, thrombocytopenia, Ashkenazi Jewish, the first thing you find is Gaucher disease. But for those physicians, they had thought about other things before thinking about Gaucher. So this is about the cost, and I think because there is now more and more importance about giving money to rare disease, you can see here what the cost for us as payers, the governments, for medication of rare diseases. And the cost of drugs for rare diseases is really astonishing, and you can see that one of the world's 10 most costly drugs are those treated for rare diseases. And you can see here the numbers of money that really cost payers to treat Gaucher disease. And always the question is really, is this needed, or can we do something about it? On the other end, and this is pictures from Pakistan, so with the courtesy of one of our colleagues from Pakistan, which since the drugs are very costly, they don't have the drugs. So in these pictures, you can see all these patients with Gaucher disease. Now you can recognize them with this huge abdomen, which we don't see them in Israel so much because we treat the patients. But you can see your patient dying in a young age from a treatable disease because they cannot afford this very expensive therapy. And there is a lot of discussion in our literature how to really reduce the cost. So we really preach for giving not the maximal tolerated one, which that's what the companies would like us to give, but really give the minimal effective dose and really try to choose a patient that need to be treated and not treat every patient that had Gaucher disease. And actually, I was privileged to write a review on this topic, really to try to give an algorithm for physicians out there that don't have so much experience with Gaucher disease, trying to give some guidelines who to treat and what doses to use to treat, especially now that we have many types of treatment. There's also a call for a cause to really influence the pharma to lower the price. And it's not easy because it costs a lot of money to produce those drugs for those rare diseases. So it's very easy for us to say reduce the cost, but when you have to expend so much money making good medication for rare diseases, it might be a problem. But joining forces in the countries and patient group association and regulators together can probably help us reduce the cost. What can we do about diagnosis delays and misdiagnosis? So we have to raise awareness, and we do that all the time by giving all those talks. We have to educate our peers. One of the things I'm trying to work now, I'm starting my PhD in public health, and what I really want to develop is some kind of machine learning. So really putting all those things together and trying to figure out how to diagnose patients with Gaucher disease. And maybe if we'll be successful, hopefully, we could have the pediatrician or the family physician at his office when a patient comes to him and he has high ferritin or some things that are related to Gaucher disease, something will pop up to him and say, think about Gaucher disease. And it's so easy now to diagnose this because we can send genetic diseases quite easily now. And if this thing will pop up, maybe we'll increase the diagnosis of Gaucher disease. There was other ways of doing better diagnosis, and this was carrier screening. So basically the idea was that if it's a genetic disease, and we know that if you have two carrier marry, you have a child with Gaucher disease, then maybe the best thing is to check the carriers to see who is a carrier, not a carrier, and then avoid getting married. And this is actually Dori Sharim, which I'm sure most of you are aware of it. So Dori Sharim is a program for couples that do premarital arrangements, and they do genetic testing for those couples before they get married, and each one gets a number, and if they have a genetic disease, they don't let them marry. The problem is, and you can see here in this title, that it can cause more harm than good because you diagnose many couples that are carriers of the Ashkenazi mutation, and most of their children will be healthy. They will have Gaucher, but they will be healthy, and there are a lot of abortions. And nowadays, carrier screening was taken out of the market for Gaucher disease just because there were so many abortions for children that would be totally normal. And we really see the changing profile of children, which are much healthier now because they are diagnosed early. The other way to go is newborn screening. So newborn screening is what is done for many, many years for PKU. I'm sure all of you are aware that when a child is born, you get poked and they put on this paper and it's sent for test. And you can really check for many important diseases. But this way gets more and more common to be done. And now more than 50 diseases can be diagnosed through this newborn screening. So it's very effective, and maybe we should do that. And you can see here the world picture, places in the world that have only 9. In the UK, in Israel, we have 12. But in the US, more than 60 diseases are newborn screened every day. And this, again, could be a good solution for diagnosis of rare disease, but it's also a problematic solution. Because you can see here the WHO criteria for newborn screening, and it has to be an important problem. It has suitable, acceptable tests, which we have. Agreed policy to whom to treat or not to treat. So if you have a disease that you are not sure who to treat or not to treat, you might be diagnosed patients or patients that are actually healthy. And you have to be a economical balance between testing and not testing. And although we are quite not sure that Gaucher disease should be screened as a newborn screening, you can see here that it's already done. And this is really a new slide from Taiwan that they screened all newborns for Gaucher disease, so it's feasible to be done. You can see here on the bottom chart that out of the almost 500 newborns that were screened, 3 of them were found with Gaucher disease. And maybe Taiwan, it's worthwhile doing it because all of them would have a bad mutation. But in Israel, we would find many more cases, and most of them will be healthy children that won't need be treatment and not to be followed until they are 20 or 30 years of age. And this is actually from a specialist in newborn screening that says that newborn screening has been a success story, but all proposed advances must be approached thoughtfully, or they could be public health disaster waiting around the corner. And I think in medicine, we always have to be aware that we have tools how to treat patients and what to do with a patient, but we always have to be aware that not treating a patient and only following him and not giving him a treatment is also medicine. So we always feel that we need to do something, but not doing anything is also an important part of us being a physician in the field of rare diseases. So other things that we won't have time to talk about it, but are also interested in Gaucher disease and can also be learned about other diseases of rare diseases. So first of all, as I said, we still have patients with Gaucher disease that we don't have any treatment for them. And this is the type 2 and 3s that have neurological involvement. And I said most of them have a neurological problem at the age of 10, 20 years of age. And some of them even die very early. And now we have thoughts about doing gene therapy for those patients or giving some kind of chaperone to stabilize the enzyme, because the treatment we have now for Gaucher disease don't cross the CNS, they don't cross the blood-brain barrier, and they are not available for these patients. Another important issues of patients with Gaucher disease, like other rare diseases, they grow up and they get other diseases. So patients with Gaucher disease can have cancer, and the big question is, are the risk of cancer is higher in patients with Gaucher disease, or some association probably with multiple myeloma? A very interesting comorbidity for Gaucher disease is Parkinson, which we won't have time to talk about it, but Parkinson was found to be associated with Gaucher disease, occurring in a higher risk also for patients, but also for carriers with Gaucher disease have higher risk of developing Parkinson. And it's a big debate what's the importance and why it occurs, but it's really ongoing topic that will lead the field forward during the next year. And if you're wondering what happened to my patients, so this is the same patient. He was found to have type 3 Gaucher disease, and this is how he's doing. How can I think if I'm...
שים את זה בפח אלישיבי.
So this is after 10 months of therapy. You see his abdomen is totally flat, and he's walking and happy, and he's still quite small for his age, but he's much better. So I think with this thinking of you don't think, you won't look. If you don't look, you won't find. And if you don't find, you can't treat. I hope this will go on with you after my talk. And this is the big thank you I have to give, first of all, to my parents and my granddaughter, which is now already 7 months old, baby, infant. So she's here, and my parents really support me all during all my career and the tough time I had in last year. So really, really thank you, and הרבה מזל טוב, and wish you all the best. And this is my great family, Shlomo, which is, I can't say more than that, and the team in Gaucher, which is this is Ari Zimran, is the great coordinators and secretary, and thank you very much for listening to me.